Okay, so we have a 58-year-old female who comes in just for retina follow-up. She has alopecia universalis, migraines, osteoporosis. Her systemic meds include diazepam, imitrex, vitamin D, Xeljanz, and Vitamin. Her vision is 20/25 in both eyes, and her pressure is 17 in both eyes. All right, take it away.
Right, so here we have a color fundus photo of the right eye. Media looks clear. The disc looks flat and round. There might be some little obscuration of the inferior border of the disc, but otherwise flat and round, flat and sharp borders. The vessels look normal in caliber. Macula looks flat, healthy. Overall, pretty normal looking fundus photo.
Here.
And then here's the left eye. Media is clear, similar looking disc. Vessels, again, with normal appearing caliber. The macula looks flat, pretty unremarkable. And then in the periphery, along one of the superior arcades, there's maybe a 6x4 disc diameter, dark, sharply demarcated, probably flat, pigmented lesion, probably a nevus.
And then what are
Lovely.
some salient, like pertinent positives or pertinent negatives that you might describe if you have someone with like a pigmented lesion on the fundus? You mentioned one of them, it looks, you said flat, and you mentioned size. Great. What about some other things that you might want to comment on?
So like the border is sharp. There's no satellite lesions. You can compare it to previous images to see if it's changed in size at all. There's no associated neovascularization or sentinel vessels.
Yeah, no sentinel vessel. You could comment on, the presence or absence of a halo, fluid, bruising, or orange pigment. Do you see any of those things?
I don't think so.
I would agree.
I do.
So sorry. There's no fluid, there's no halo. I don't think there's orange pigment. This might be.
Yeah, that's
question.
Yeah, exactly. That is.
That is orange pigment?
Yeah.
Those drusen on it.
And
And
then
they're
there's
drusen.
orange drusen. Yeah, all over the yellow spots.
Is that elevated at all where the drusen is?
I
You
think
can't
it
tell.
looks
It's a
similar.
two-dimensional image.
Yeah.
That's number one.
It doesn't look
And
like
it's-
you're pushing
if it's
flexible.
elevated, it's not so elevated that you're getting monocular hits.
Yeah, this looks pretty flat over there. Oh, that's a closer up picture. So here's that area concerning for me.
That is very orange.
Orange, a few like brushed pigmented orange spots there.
Yeah.
And then also the bruising. And I'm over it.
Yeah, it's orange in color, but is that pigment or is that the underlying
It's,
RPE?
it's what we call orange pigment. I don't know.
Yeah.
I don't know how to answer your question.
More studies.
It's a
to
risk
follow.
factor. It's a positive risk factor.
No,
It's a horrendous positive.
because
risk
everything
factor.
around it is orange too, the whole retina is orange.
Well,
Sometimes the
whole
world
okay.
It's Florida.
All right, sorry, Grant, take it away.
So is this autofluorescence
No,
or
Says on
IR?
the bottom.
yeah.
It's IR. Okay, so we have an IR photo of the lesion. It's highly reflective throughout. Yeah.
And then this is your autofluorescence.
So there's some overall the lesion is hypoautofluorescent, and then there's sort of a wedge of hyperautofluorescence along the superior margin of the lesion.
And then, interestingly, a couple of things. So the hypoautofluorescence can signify some chronicity to a lesion. Remember we said like bright stuff is sick and black stuff is dead or something that's been there a long time. So it could be that, or it could just be that the it's the pigmented lesion itself. You would expect the drusen maybe to be a little bit bright, and then those areas that were kind of brushed with orange, you would expect them to be pretty bright. Remember on the autofluorescence, one thing that gives you the brightness that we mentioned earlier was like the lipofuscin or the window defects. I don't know. I didn't see anything that corresponded like
Yeah, I don't
here
either.
to give us that bright
I don't-
spot.
I
So
don't
I don't.
I think that's probably a window defect. It's interesting if you, the nevus can't really block the autofluorescence. Who is this? Grant? Well, Grant,
Yep.
what's the autofluorescence come from? What tissue layer? Do you remember? Roughly, most of
The lipofuscin and the RPE.
the RPE, right? So the autofluorescence from the RPE, the nevus is under the RPE, right? So the nevus can't really block the autofluorescence, but it can damage the RPE so that it's dead. And then the window, you can get a little window defect if there's retinal atrophy, or that thing on top might be a very retinal atrophy if you scanned it. Out of retinal atrophy.
Okay.
So here's a B scan, presumably of the lesion. It looks like there's some, what's the term, hyperreflective part of the lesion. Thickness, probably less than 2 millimeters. Yeah, I would say that.
The scale in the upper right,
Yeah,
that's less.
Sorry. And then just another cut too. So on bead scan, like you mentioned, you want to describe the size, and I think that's what a lot of people use it for, but also the shape. So is it flat, dome shaped, is it mushroom shaped? I read in one study, there's a statistic that said that the B scans overestimate the size of the nevus by 126%. So I don't know, nowadays if the OCT can, or the technologist, depending on where it is in the periphery, can put the OCT over the nevus, you might get a little bit more accuracy there. But all right, so do you want to summarize the findings and give us your differential?
so we have,
So in the studies, the thickness is based on these old B scales.
Oh,
So they're actually the gold standards. The OCT is underestimated.
okay.
You can look at it two ways. But for this purpose, it's the size on B scale.
Right.
Go ahead. Differential.
also, for differential, I would say like a choroidal nevus versus something more concerning like a melanoma. Could also have like a chirpy.
That's good. I put like a metastasis on the differential as well, and then it looks different, but maybe a melanocytoma. And what do you think this is? I would have to give you a little bit more history to help you if I told you that this was exactly the same appearance for 10 years. What would you
Probably
say
a
this-
nevus.
Yeah. So this was a choroidal nevus. So in general, they're brown to slate gray. And I won't belabor all of this because Dr. Pavan last time gave us a really great lecture on this, but just kind of hit the highlights. Usually there is distinct but mildly blurred margins where the color of the nevus kind of blends into normal retina. Usually flat, or if it's elevated, it's not a lot. And usually 91% of the lesions are posterior to the equator. The prevalence is 5% in adults above 40. Usually, the epidemiology and the statistics say that there's equal prevalence in men and women, but there are some studies that show in women who've delivered babies prior to 20 or prior to 25 compared to women who deliver babies after 35 have a higher incidence of choroidal nevi. And then same for like in the postmenopausal period, women who are more overweight or obese also have a higher incidence of choroidal nevus. So the thought is that if there's a higher lifetime estrogen, it might increase your risk. And then it varies by race. So whites 5.6%, Hispanics 2.7%, blacks 0.6%, and Asians 1.8 to 2.9%. And then questionably, does it vary by nutrition? There's some stats out there that say that higher levels of vitamin C were inversely correlated with so it was a protective factor if you had a high level of vitamin C. Usually they're asymptomatic, but it depends on the real estate of where the nevus is and the anatomy of the fundus. And when a nevus causes degeneration or dysfunction of the overlying RPE, you could get fluid that accumulates or CMV, and then that would cause symptoms as well. And so the most important thing is to kind of put this in your mind as, is this something that's benign? I'm not worried about this at all. Is it benign, low risk, or is this more higher risk and concerning for a melanoma? So there's that big important factor is time, is how has this changed over time? And then the to find small ocular melanoma using helpful hints daily mnemonic. So that gleans at the thickness, whether there's subretinal fluid present, is the patient symptomatic from the lesion, is there orange pigment, is it within 3 or the margin of it is being less than 3 millimeters from the optic disc, is there ultrasonographic hollowness, is the halo absent and the drusen absent. So if there are greater than or equal to 3 of these risk factors, it portends greater than a 50% chance of transforming to melanoma within 5 years. And this is another table that just summarizes the same with the hazard ratios. And so generally, if nevus doesn't have any of the risk features that we talked about, it's you can monitor it annually. If there's 1 or more risk factors, in 4 to 6 months, and then you can probably tailor that. So if you follow someone who had like this orange pigment and you follow them for 5 years and it didn't change a wink, it would probably be okay to extend the follow-up a little bit longer. And so this one was first discovered in 2012, and all the old images are about the same. So it was about 10 years that it hadn't changed.
So you should go to the melanoma calculator and take a look at that. So I would have, if I had seen this patient once, I would have said 6 weeks, and then I would have done 3 months. And being slightly anal compulsive, I'd probably go 3 months, 3 months. Might go up to 6, but I would not go annually with orange pigment. And the other thing we don't know is it's always been assumed that if they're going to grow, it's a linear process. And past results don't predict future returns in the stock market. I'm not sure that that's a fair assumption, because if they're going to turn nasty, they may be dormant for a long time, and then they'll start to grow a lot. So I have ones with like almost all the risk factors that I followed for 10 years, and he did fine, didn't grow. So you just, each one is individual.
Read, after 5 years, would you push it out or still say so?
I'm not, well, it depends on how business is,
I like to, but I don't know the right answer. That's nice what you put on it. They don't have any risk factors to go in.
Certainly, if they get, as they grow older, I would think the risk would be higher. As they
Yeah,
grow
sure.
older, so I probably wouldn't stretch
Push
it
it
out
after
after
6
time.
months is.
I never could figure it out. So,
Yeah.
but
Right.
it's the most boring thing in the world.
It's really boring.
I mean, really, it makes
Yeah.
it boring, and then you gotta do the ultrasound. Ultrasound was not done by a physician. I mean,
So-
that makes it easier. I used to do my own. It's just miserable. I'm trying to
So
find
just
something
as an
small like
aside,
that.
I saw one of your old patients,
Huh?
right? I saw one of your old patients last week or 2 weeks ago. And I'm looking at the chart before I see the patient. I'm like, yes, sickle cell retinopathy in one eye and ocular melanoma in the other. That's weird, because automatically I'm thinking it was race, and it's certainly you treated him for an ocular melanoma.
When I
I was like, wow.
when I first came on
Yeah.
to my internship in Cleveland, I remember this. They said, well, this black man has metastatic melanoma. And I said, well, blacks don't get melanoma. And the answer was, tell him that.
Yeah, that's good. Right. Is that all set? That was excellent, Sabrina.
Yeah.
And good discussion. That was Grant.
Yeah, great job, Grant.
Thank you, Grant. That was excellent. Madeline, you want to queue up next?